led the design, implementation, and evaluation of a harm reduction academic detailing program with SHRED the Stigma, a grassroots syringe service program in Oklahoma City. They earned a master's degree in public health from the University of Pittsburgh. So we are delighted and excited for your presentation. So you can take it over. I appreciate you stepping up and going first.
Happy to. Thank you so much. Thank you all for joining, and thank you to the Bridge team for inviting me here today. I'm here to share a story about SHRED the Stigma, this harm reduction program that I worked with in Oklahoma City, and how our experience with the harm reduction academic detailing program connects to a broader national effort led by NACCHO, or the National Association of City and County Health Officials, to expand harm reduction capacity. I'll cover three main pieces today. First, the context for why harm reduction education is needed. Second, I'll share SHRED's case study and what we learned from people with lived and living experience. And third, how these lessons connect to NACCHO's new implementation guide that's designed for communities like Erie County who are building this capacity right now. SHRED the Stigma was founded in 2021, immediately after Oklahoma decriminalized syringe services programs, and our mission is simple but ambitious: to end overdose and other drug-related harms through realistic and achievable approaches to drug use. We started this by delivering safer use kits. You can see an example there on the right, with things like sterile syringes and naloxone and wound care supplies, and all of these things that you are already familiar with, delivered directly to people's homes in the Oklahoma City metro area. Everything was volunteer run, so advocacy was kind of a scary word for us at first. But with this project, we've started to expand into new ways to help kind of shift these local conversations about drug use. From personal to professional experience, I'm sure everyone here is aware of these harms of drug use, and I know we'll hear some statistics later on, so I won't bog you down too much with that. But these harms go beyond the drug use and the drug itself. These are Oklahoma-specific statistics, but we've seen the story all across the country, skyrocketing overdose deaths from 2019 to 2022 especially. Over 100% in Oklahoma, especially among people who could have been helped, who had opportunities that were missed for intervention, and including healthcare system costs that could have been prevented. Of course, we also have human immunodeficiency virus, or HIV, and hepatitis C, which are transmittable through unsafe injection practices, and other medical and legal and social harms and stigma and housing instability, and all of these issues compounding that as well. All of these making up this public health burden that the war on drugs has created. One of the issues is that these harms aren't being fully addressed in clinical spaces, and this was the focus of SHRED's project. Traditional approaches to care tend to emphasize abstinence-based treatment, criminalization, and emergency responses to acute health crises. And while these services, some of them are life-saving, they're not fully addressing these underlying social and structural determinants that are leading to these poor health outcomes, being discharged against medical advice, being readmitted for infections, the same infection over and over, delaying your healthcare access and experiencing poor health outcomes overall as a result. When people who use drugs do have access to healthcare, they are experiencing stigma, they're facing this discrimination, and they're facing these poor health outcomes too. And so instead, we look towards harm reduction as offering a different approach to clinical care. Harm reduction broadly refers to these policies and programs and practices informed by these underlying values that seek to minimize the negative consequences of drug use without requiring abstinence. There is ample evidence at this point to support harm reduction initiatives and their effectiveness at decreasing HIV incidence, building trust with providers, improving adherence to care. And so as a result, major trusted health organizations have expressed their support that this is something that we need to be incorporating. For clinical practice specifically, you can see an example list of values. Others, like the National Harm Reduction Coalition and Harm Reduction International, have their own lists of values. You can find one that speaks to you. But for these specifically tailored to healthcare settings, they are humanism, or respect and dignity for patients as whole persons; pragmatism, or the recognition that perfect health is not an achievable goal; individualism, or the fact that no one solution works for every patient; autonomy, or patients having the ultimate say in their choices of health behaviors; incrementalism, or the celebration of any gradual positive change towards improved health; and accountability without termination, or the responsibility that patients have for their choices and that providers have to continue treatment, not punishment. Together, these principles provide a foundation for this project's core components that are aimed at increasing access to and quality of healthcare services for people who use drugs. And we know these harm reduction principles exist. There's resources out there, but clinicians aren't receiving this education. Opioid use disorder wasn't even a mandatory part of medical education until 2019. Out of a dozen or so programs teaching harm reduction at all, there were none in Oklahoma, where we were based. And as a result, clinicians feel unprepared and report feeling unprepared to treat their patients who use drugs. Lack of knowledge, lack of consequences, or fear of consequences, lack of time for appointments. And so we focused really on education as this first step to changing behavior. So with this clear need for improved healthcare access, with clinicians lacking education on harm reduction, we saw an opportunity for a program. And that project was this piloting of a clinician education program about harm reduction, designed, and was really the core of it, designed with input from experts of experience. Our goal was to really understand these barriers and facilitators to accessing healthcare. We have all of this data, all of this evidence to support it, but we really wanted to also humanize the issue, bringing folks together for focus groups and a really kind of fun participatory research method called photo voice. We sought to recruit participants who we already knew from the syringe service program, from varied backgrounds. These were mothers and veterans and artists and unhoused people and your neighbors, and really just people with a story to share. We brought them together for focus groups in private community spaces, led by volunteers, so familiar faces there too, who facilitated these conversations about past experiences with medical care, developed with input from our community advisory board. And our participants reached a really clear consensus on what those barriers were. I'll send slides after this, so you'll have this to read through, but broadly, that healthcare is expensive, that participants felt judged and misunderstood. Participants avoided seeking care. Participants had better experiences if providers took the time to listen. And participants found other ways to get their health needs met in the meantime. And I'm sure you've seen similar stories with the clients you serve or the folks that you know. But with these answers, we also wanted to dig deeper with a method called photo voice. We introduced this concept at the first focus group, shared cameras with the participants. Either they could use a disposable camera or their cell phone and capture photos that answer these prompts of things like, what does a safe place look like? What would you want your doctor to know about you? Really open-ended and kind of allowing them to guide where they'd like the narrative to go. For practice, we shared pet photos, and that was really a fun, popular icebreaker too. And the results that we got were really incredibly moving. Again, I'll let you go through these at your own pace after this. They had just a simple photo with a story combined, made these really, really powerful to see. And so, with the voices of our participants and with supporting data from the literature, what we had was evidence. And academic detailing is essentially turning evidence into practice more quickly. There's an oft-cited number that it takes like 11 or more years from research to turn into clinical practice. And people will die in the meantime. So we set out to kind of speed up that process. Academic detailing is a unique form of clinician education. It is a series of short one-on-one meetings, usually closer to 10 to 20 minutes, that borrow some of these same approaches that like pharmaceutical sales reps used in kind of starting this opioid epidemic, but without this commercial agenda. So it's this semi-structured, open-ended conversation that begins with a needs assessment, moving into sharing key messages, features, and benefits tailored to the specific provider you're speaking to. Then we listen for barriers and objections and end with this small, ooh. Thank you. Can you see? Great.
Yes, thanks, Jay.
Sure. You didn't miss too much, but it has the structure ending with some small agreed upon change for next time, with this goal really being not to overwhelm providers by throwing everything at them at once, but by giving them small, practical, evidence-based steps that they can act on today. We selected clinicians as this target population for the potential impact that they could have on improving healthcare access. Primarily, according to our participants, at emergency departments and free clinics was most important to them. And then later on, in part because we were getting kind of a slow response rate, we expanded that to include non-clinical staff and students, pre-health students, who were much more engaged. These are often the first point of contact, and they also have this ability to influence how patients are treated. We reached these folks really from cold calls. We didn't have these existing relationships to begin with. So word of mouth, referrals from other organizations was really important in getting that going. Our key messages, you can read these. They were set to be actionable, measurable, designed to move this practice one step closer at a time to the safer care. Focusing on things like screening, naloxone, these really common kind of harm reduction practices that you can incorporate. To measure impact, we used pre and post-test surveys. The response rate for that, again, was low. One lesson that we learned was to make that survey part of the visit itself. But in the end, we found we had 8 healthcare providers who participated. They tended to have a high baseline knowledge of harm reduction, but they really appreciated that this offering was unique, that this was not something that they had access to from anywhere else. We also had many more pre-medical undergraduate students participate. We adjusted the key messages for these to focus more on knowledge and less on practice, of course. But we found that students were really powerful messengers. They took what they learned back to their clubs and their workplaces and shadowing physicians and social networks. And so we saw some adoption of these key messages, but we also saw some exciting wins that we didn't expect. For example, one hospital added safer smoking machines or safer smoking kits to the vending machine that they had at their clinic. And that's a shift that was small, but really meaningful. Lessons learned from this project, it's a start, and even small steps like that matter. We learned that defining the audience was really key. Because this is a voluntary service, we didn't have the authority to mandate something like this. Every provider who agreed to meet with us had already given us that one yes. And so we were really starting on a good foot, which I think helped. I would also recommend partnering with well-known organizations to help build credibility, especially offering CME credit, things like that. But the bigger questions that we had are, and I'd love for you all to consider this too, how can an approach like this be scaled up from these one-on-one meetings? And how can an approach like this be used to improve access to healthcare for other populations, right? This is something with promise outside of just harm reduction. Lastly, I'll share a little bit about NACHO's guide. SHRED wasn't alone in this. This was part of a program with 19 sites across the US, including SHRED. NACHO brought these sites together and learned these lessons from our work and captured these in their new practical guide for increasing harm reduction capacity through education and community collaboration. Say that 10 times fast. But it has information on selecting your audience, developing these materials, conducting outreach, and evaluating the project. Again, selecting the audience is really going to be the core of how your program operates, is based on who you're going to be talking to. You would choose an audience based on what you want to happen, based on your relationship. So like SHRED's kind of struggled with some of this medical outreach. If you have those existing relationships, it would just be that much easier. Does the target population have the time and availability to meet with you? And can you incentivize that engagement? Any gaps in knowledge or attitudes that the audience has, barriers that might interfere? Medical settings are really kind of the traditional site for harm reduction academic detailing, or for academic detailing altogether. But that's not the only audience out there with the potential to learn more. Other sites across the country chose faith-based leaders and police departments and fire departments and drag queens. It really just depends on that local context. Next up is developing responsive materials. Really, the central takeaway I hope you get from this is that the meaningful engagement of people who use drugs is what makes this work. So we were able to bring people together for focus groups and share photo voice with them and get these stories from them that really were critical to making this program work. Part of that engagement looks like closing the feedback loop. So not just asking a question one time, but coming back and saying, okay, here's what we've got. Like, does this represent your story fairly? Really making this an iterative process. With these engagement, I will get to that, thank you. With this engagement, draft your key messages, incorporate that local data, and then with all of this together, put together an action kit to really reinforce these key messages. Parts of an action kit could look like, there on the left, SHRED put together our own guide based on what people said. We had a document with the stories and the photos that we could really on that first meeting just sit down with and just get kind of a baseline understanding of people are people. Journals, scientific literature, things like that, local surveillance data, publications, whatever else you have available. For example, we had one of the key messages about naloxone, and so a supporting action kit material for that was having Narcan to have on hand that we could give to the doctors, that they could then give to their patients, and not deal with the process of getting a prescription and jumping through all those hoops. Other sites beyond Photo Voice, which was resource intensive, other sites used things like a participant advisory board, key informant interviews where you sit down one-on-one with like a specific chosen expert over what these messages should entail, focus groups again, surveys, really whatever you do to hopefully get that community engagement already. And then the outreach itself. This can look very different, again, based on who you're talking to, if they're expecting academic detailing or not. For clinicians, that might look like emails, cold calls, tabling at professional events. For non-traditional audiences, that might be a lot more of that tabling and that in-person outreach. or relying on personal referrals. What matters is tracking your contacts in something like a spreadsheet or whatever else you would use to keep track of what works and what doesn't. And so, for example, with SHRED, when we saw that cold calls and emails to clinicians were actually not working well for us, I suspect they just didn't know who we were and sent that to spam with the rest of it. Can't blame them. We found that cold calls worked better for these pre-health students who were getting emails with opportunities all the time, and we're looking out for that. And then for clinicians, we changed our focus a little bit to more of that word of mouth referrals. One clinician who had a great experience could get us in, maybe not for academic detailing, but for like a larger group training, a lunch and learn like this. Having that advocate, though, helped. And so it just really looks like being flexible, pivoting when you need to, focusing on chasing those successes. And then last, evaluating the project. This is something you should be doing throughout, based on your organization capacity, kind of from easiest to hardest. Just having that spreadsheet is part of your evaluation. Field notes that your detailers are taking with notes on what worked or did they like this key message. Pre and post surveys are great if you can get survey responses. Find what works for you. Keep in mind that this long-term change of incorporating behavior changes is slow. Our program lasted only 9 months in total. This was just a short-term pilot project. So you might not be around to see if those messages stick, but also consider these unexpected successes. Talked about the smoking kits in SHRED's experience. But in Utah, for example, detailers who worked with the fire department were able to establish their first statewide syringe program. In Ohio, they were able to get harm reduction literature placed in waiting rooms in a hospital system across the state. And so these wins matter too. And it's absolutely something that any of your organizations could do. I'll end with this. Academic detailing isn't just about training, it's really about building these relationships to change systems. And so this NACCHO guide is a practical tool. Read it, use it, but know that this real impact comes when communities like Erie County take it and make it your own. And so whether you're working in healthcare or law enforcement or public health or grassroots community organizations or whatever else, you have a role to play here in shaping how your community responds to drug use. So I'd love to invite you to think about who in Erie could benefit from something like this. What's a small step that you could take today to start that conversation? And really every step, it's a step-by-step process to bringing us closer to healthier communities. So happy to take any questions at this time. I see we've got a couple in chat. I'd love to continue supporting your work, important work in this space after today. So please feel free to contact me there. And let me look through these questions. I believe I answered about medical providers. Thank you for sharing that photo voice. I really appreciate kind of that history of harm reduction too. Any other questions? Great. Well, again, thank you so much for inviting me here today. Wonderful to speak with your group. And again, if I can be of any other help, please don't hesitate to contact me.
Thanks so much, Jay. You are awesome.
Yes, I loved the photo voice. What a cool concept. I can't wait to look back at the slides again. Hopefully you can share those with us so we can, look at those more closely. But thank you for sharing, and hopefully we can continue this work together. Hopefully, next up we have our data analyst, Jason Merlin, who will be sharing some overdose data from Erie County. I can hear you.
Yes, can you hear me? Marilyn was gracious enough to lend me her machine, so I can be heard okay here?
Yes.
Great.
Yes, we can hear you, and I just gave Marilyn permission to be a presenter, so you should be able to
Okay.
be able to share. Yay!
Yay, looks good. Okay. Well, yes, thank you, Jay. That was an excellent presentation. And academic detailing is something that we've started to look into very recently, and that we're going to touch on something related a little later. I apologize sincerely to the audience for my audio issues earlier. Hopefully we should be good from here. So let's get started with the data updates for Erie County as of September. So this is first, we're going to look at our overdose deaths in total for the year and over time. This is cases reported through September 23rd, so very recent updates. So far this year in 2025, we've had 180 confirmed and probable overdose deaths. Of those, 98 were confirmed to be opioid related, 46 were confirmed non-opioid related, and 36 are still waiting for a toxicology report. If we continue on at this pace, we are on track for another annual decline from the 2024 overdose deaths, which was a significant decline from the year prior. So we're looking at potentially coming in at about 250 overdose deaths for the year, or potentially even less. So now we'll look at some overdose death demographics, look at the overdose deaths broken out by different age and race categories. So here what we're looking at is population adjusted overdose deaths by race and ethnic groups. So we're looking at population adjusted deaths among the Black population, Hispanic population, and the white population. And what the population adjustment allows us to do is to see which groups are overrepresented and underrepresented among overdose deaths by controlling for the size of that population in the community. So we can see in this chart that goes back to 2020, over the past several years, the Black overdose rate will be, yes, I see some questions about the slides being shared. I believe they will be. Over the past several years, the Black overdose population adjusted death rate has increased dramatically, peaking out at roughly 120 deaths per 100,000 residents in mid-2024. So if you do the math on that, that's more than 1 out of every 1,000 members of our Black community that were dying every year, 1 in 1,000, or even less, more like 1 in 800, at an alarmingly increasing rate. But fortunately, beginning around August of last year, we saw the death rate among the Black population decline very significantly by more than halved, from 117 deaths per 100,000 to 46 deaths per 100,000. Now, that still is a significant overrepresentation compared to the population level, but significant. We've come a long way from where we were a year ago, and that disparity is starting to close. We see a similar trend, although not as extreme, among the Hispanic population. Also has decreased significantly over the past year, and white overdose deaths have decreased as well. So deaths are down across the board, but the most extreme decrease that we've seen is the decrease among the Black community, which is very encouraging to see. Looking at age, this is the same population adjusted concept here, but broken out by age groups instead. We're going to go from the bottom to the top here. So that bottom line is ages 29 and younger. And we can see that over the past year, that death rate has fallen, although it was already our least affected age group, and it has now fallen even lower. The next affected age group, the purple line, is ages 60 and older. That age group also had a significant decline in the past year after a pretty startling rise throughout 2023. If you have been an attendee at our previous task force meetings from the past year or two, you'll recall us noting this alarming trend of a substantially increased overdose rate among people aged 60 and older, but that has started to reverse as of the past year. Next, we have the 30 to 39 age group. That group has had a very significant decline, more than 50% over the past year. Previously, back in 2023, that was our most affected age demographic, the 30 to 39 age group in the orange line. But it has fallen significantly below some of the other age groups. Next, we have age 50 to 59. That's another age group that has seen a very, very sharp decline over the past year. Used to be up there with our 30 to 39-year-olds back in 2024, roughly a very similar number, but it has fallen substantially. The one age group where we haven't seen as significant of a decline, although we still have seen somewhat of a decline, is the 40 to 49 age group. This is one that we hadn't really focused on in prior data presentations, but as of the past year, the population-adjusted death rate of 40 to 49-year-olds has remained stubbornly high and has not seen the dramatic decreases that we've seen in some of the other age groups. So just interesting to note. So now we'll look at toxicology. These are the substances that are detected by the medical examiner's office in overdose deaths. And these percentages are the average of the past 6 months of overdose deaths up to that point. So 6-month periods and the percentages of each drug category represented here. So the first thing we'll look at is the blue line for deaths where both opioids and cocaine were detected. We've seen a significant decline starting in 2023, but persisting and accelerating through 2024, where a year ago, opioid and cocaine in conjunction was more than half of our overdose deaths. And now that's closer to about a third. So we hope this trend continues, but it does seem to reflect a potential change in the drug supply of fentanyl and cocaine being found together less frequently. Opioids only being detected in absence of cocaine or other substances has increased somewhat, very mildly, sitting at about a third of our overdose deaths. Cocaine only in the absence of opioids has increased from 13% to 21% over the past year. And so that's a trend that we are monitoring very closely. It does seem like we're seeing a general rise in overall stimulant-related deaths. So we'll be tracking that through the future, and perhaps breaking out a new category here of stimulant-related deaths, incorporating methamphetamines and other stimulants along with the cocaine deaths, because we've seen that rise as we've seen opioids deaths fall. And that other substances category has increased as well. That's things like amphetamines, benzodiazepines, and other things that aren't even controlled substances, such as Tylenol, acetaminophen. Any other substances are in that greenish line. Anything that does not contain cocaine or opioids. So we're seeing that increase, and in general, we're seeing kind of a more diverse range of substances in our death population. It used to be predominantly just opioids and cocaine, but now we're starting to see a much greater range of substances. So now we'll look at overdose deaths by zip code. We're looking at 6-month periods here by zip code. On the left is September 2024 through February 2025. On the right is March 2025 through August 2025. In September through February, the areas with the most deaths were 14207, which is the Black Rock Riverside area, 14201, which is the Lower West Side of Buffalo and Allentown, and 14215, which is the Upper East Side bordering Cheektowaga. In the most recent 6 months, from March through August, we see 2 of those zip codes pop up again, 14207 and 14215. But we did see a significant increase in deaths in West Seneca. We had 7 overdose deaths in West Seneca, 14224, in the past year. And that was a rather significant increase, and is something to be monitoring. Other areas with high numbers of deaths are broadly the east side. We can see Broadway, 14212, had 6 deaths in both time periods. And broadly, the east side sees a lot of overdose deaths, although it has decreased in recent months. Now we're going to talk about a little bit about our forensic lab data. So Erie County law enforcement will sometimes seize samples from a crime scene and send that to the Central Police Services Forensic Laboratory to be analyzed to detect what substances were present and any any narcotics or any other illicit substances. In 2025 so far, we have had 72 samples analyzed, and here are some of the contaminants that have been detected. We can see the chart on the right is by month, and it's showing medetomidine, BT-MPS, and xylazine detections. So we had 6 medetomidine detections. Medetomidine is another veterinary tranquilizer similar to xylazine that we're starting to see pop up in the drug supply. BT-MPS is like an industrial chemical that doesn't have any pharmacological uses, but it's something that we've been seeing pop up in the drug supply quite significantly. We've had 12 detections so far this year, 3 of which were in July. So this is an emerging contaminant that seems to be present in our drug supply here in Erie County. We also had 8 xylazine detections, which is another veterinary tranquilizer that has been that is known to be in the drug supply and has been for some time in Erie County. Hence the xylazine test strips that we give out. So this is something that you can expect to see more of from us as we keep tracking these contaminants and see if there's any new ones that emerge. But for now, the ones of primary interest are medetomidine and BT-MPS. So we'll look at a comparison of Erie County's overdose death numbers to the statewide trends. The CDC puts out overdose deaths by state, showing a change over time. Their data was is through April, is their most recent data point. As of April, New York State had seen a 37% decrease year over year from April the previous year in overdose deaths. At that same point in the year, Erie County was at a 29% decrease. We have a little more current data, so we can look through August. We are now at a nearly 40% decrease year over year from overdose deaths a year ago. In the 12 months leading up to August of last year, so August 2023 to 2024, we had seen about 35 deaths per month. So that's more than one each day. Very high number of overdoses. And in the past year, from August 2024 to 2025, we've seen about 21 deaths per month. So still far too high, but that's a significant decrease, a 40% decrease in just a single year. So our overdose deaths do seem to be lagging slightly behind state trends, where you seem to catch up to the statewide decline a few months after they hit that benchmark. But it has been a very continuous line down for the past year, which is very encouraging to see. So we'll talk a little bit about our non-fatal overdose reports. These are aggregated by our local high-intensity drug trafficking area office, our HIDA office, and tabulated by our internal OHR team. We really have to thank HIDA tremendously for all the work they do in getting us these reports on a daily basis. They enable us to do a lot of the work we do with case follow-up and with mapping and all that. So thank you to our HIDA office for that. This is showing basically our average non-fatal reports per day over the past several years. We can see we fairly consistently get about 2 or 3 non-fatal reports each day. We had an anomalous spike last September where it went up to about 4 or 5 reports per day. Often we see some level of seasonality where we see fewer reports in the colder months than we do in the warmer months. So we can see in the months leading up to where we see March 15th, we had less than 2 reports a day, so much fewer than we typically expect. But since March, in the past several months, we've been seeing more and more reports, and now we're actually towards the high end of our range, where we're seeing about 3 reports per day. So just to kind of give you an idea of the volume, it works out to be about 1,000 reports per year. Looking at where these reports are occurring, this is another 6-month comparison. We got September 2024 through February 2025 on the left, March 2025 through August 2025 on the right. The most notable zip code with increased reports is 14206, which is the Lovejoy area, which is just south of Broadway on the east side of Buffalo. There we saw a rather significant increase in overdoses, in overdose reports. As always, we know there is significant underreporting of overdoses. We know we're not getting the full picture, but based on reporting, we're seeing an increase in the Lovejoy area. Decreased reports, we see fewer reports in Cheektowaga and the Broadway area. So rather interesting that we saw reports go down in Broadway, 14212, but in the zip code immediately to the south of that, 14206, we saw an increase. So it could be activity shifting from that zip code to the other, or it could be new pockets of activity popping up. Areas with consistent levels of high reports, which we've talked about in previous task force meetings. Broadly, the west side and Black Rock Riverside, so 14201, 14213, and 14207. Those are a continuous block of zip codes on the west side of Buffalo, including the Black Rock Riverside area, where we persistently see our highest levels of non-fatal reports. Comparing overdose deaths to non-fatal reports. So this is March through August with non-fatal on the left and fatal on the right. There are several areas where we see more deaths than we would expect given the number of non-fatal reports. So in these areas, we see not a whole lot of non-fatal reports, but we see a high number of fatals, and that's 14212, 14215, and 14224. So the east side of Buffalo bordering Cheektowaga, the Broadway area, and West Seneca. We see fewer deaths than we would expect in some of those west side zip codes, 14213, which is the Grand Ferry area, and 14201, lower west side in Allentown. There we have more non-fatal reports than we would expect given the number of overdose deaths. So yeah, some interesting comparisons there. I'm going to talk very briefly about the prescription monitoring program dashboard, which is this is a dashboard that's run by the New York State Health Department. It has 14 metrics related to opioid and benzodiazepine prescriptions. You can compare your county to other counties, and it tracks improvement across these various metrics over time. And our county is actually working with the State Health Department directly in order to obtain more detailed data on this. Actually, ideally for the purpose of performing some academic detailing, like Jay explained earlier. So a couple of the metrics that we are particularly interested in. First is essentially prescriptions of buprenorphine that are prescribed continuously for 6 months or more. For those of you who may not be aware, buprenorphine is a common opioid replacement therapy for medication-assisted therapy that is intended to get people off of using other opioids that they might get off the street. And so we're trying to get that number to go up. We want more people to be prescribed continuous buprenorphine prescriptions for opioid use disorder, as opposed to shorter-term prescriptions that that they might fall off of. So if we see this metric go up, it indicates that more people are sticking with MAT, and that providers are on board. Another one of those metrics that we're interested in is opioid naive patients. So people who have never had opioid support before, who are prescribed more than 7 days for with their first prescription. And that metric is an indication of potentially of overprescribing. So for that first metric, it had not changed from year to year, but New York State rated us an area of low concern. So that's a good thing. For the second metric, New York State says that we improve from year to year, and that this metric is of moderate concern. So you might hear about more of these metrics in the future from us, and we're going to be using some of this hopefully more advanced data that we can get from New York State to do some academic detailing, potentially with some of our providers. I'm going to briefly go over some of our heat map updates, where we look at overdose frequency across the Erie County, the city of Buffalo. So many of you have seen these before if you've been to these past meetings. But our data source for these is, once again, HIDA. HIDA aggregates all of our law enforcement reports and emergency service calls. We get both fatal and non-fatal reports, although about 3/4 of them, 75%, are non-fatal. They send us to them on a daily basis. HIDA determines which calls are OD events. They screen them and they send them over to us. Heat maps are specific to a location and a time period, and we're going to be looking at 8-week periods within the city of Buffalo. If you haven't seen these before, a helpful analogy for how these work is you can think of an overdose report as like a pebble dropped in some water that makes ripples. And we can show where ripples overlap, and the more ripples that overlap, the hotter the cluster is going to appear. And we use a color scale of yellow to red to display this. So here is an overall view of the city, and I'm going to look at each different sub-region of the city, and we can draw some comparisons. I'll try and go quick because I know we're short on time. So first, we're going to look at the northern region of the city of Buffalo. This includes Black Rock Riverside, North Buffalo, and the University Heights area. So if we look at the area labeled A, this big circle just north of Buffalo State University, we see in the previous 8-week time period from June and July, we had a cluster near the intersection of Military Road and Amherst Street, and then another smaller cluster near Hurdle and Elmwood. And then in the later time period in that circle A, we just see one cluster that's kind of between the two, and that's centered directly on the intersection of Military and Hurdle. So lately, Military and Hurdle has been a significant hotspot. If we look at the circle labeled B, in the earlier time period in June and July, we saw a very significant cluster around the Amherst Street station on Main Street. So that's right near the intersection of Main Street and Amherst, right around that rail station. We saw a very significant, very centered cluster. In the later time period, we see decreased activity. We do see a cluster, a very small cluster right on the Amherst Street station, and we see another one nearby, right near the 33 and ECMC. So kind of the activity there kind of diffused a little bit. If we look at the area labeled C, that is in Riverside, right near the intersection of Vulcan and Skillen. And we can see that was a very significant cluster in June, July, not so much in August, September. And lastly, D, we see a cluster that's along Bailey Avenue between East Amherst Street and Winspear. That's a new cluster that we see in the current in recent weeks that we haven't seen, that we didn't see earlier in the summer. Next, we're going to look at the east side of Buffalo and South Buffalo at the same time. First, we'll look at A. A is in South Buffalo. We see a cluster that moved north and gained intensity. So that in the earlier time period, that was closer to Tift Street, so a little further down in South Buffalo. Later on, it shifted further north, like right over the Buffalo River, like right when you get into South Buffalo, closer to like, McKinley Parkway, South Park Avenue, further up north. If we look at B, that's includes the intersections of Broadway and Bailey and Bailey and William Street. And we see in June and July, we had a significant cluster right near Hennepin Park and East Lovejoy. So that area in Lovejoy, south of Broadway, that's where we saw a significant cluster there. In looking at B in the later time period, in August, September, we still see a cluster right near East Lovejoy Street and Hennepin Park, but we also see another cluster right near the Broadway and Bailey intersection. So that's worthy of note. In the area labeled C, we see a cluster that's right near Clinton and Fillmore and Fronchek Park. That was a rather significant cluster earlier in the summer. Not really any activity there later in the summer. And lastly, D, we had some activity in the Delavan Grider area that shifted around a little bit. So activity towards the Pine Hill area that is pretty consistent in both time periods. And then lately we saw some activity pop up near where the 33 meets ECMC. Looking at this kind of the center of Buffalo, downtown, and the west side. If we look at A, the area A is basically Niagara Street, on the lower west side. We can see earlier in the summer, tons of activity all along Niagara Street. Pretty diffuse throughout the west side. We saw it settle down quite significantly later in the summer, where those clusters were mostly around Prospect Park and the intersection of Niagara Street and Carolina Street. So we kind of saw the activity on the Lower West Side calm down and kind of condense into two distinct areas, as opposed to being kind of very widespread and intense along the entire area. If you look at B, that's downtown near Lafayette Square. Yeah, I know I'm wrapping it up. Yeah, so activity settled down in area B. And area C, that's an area near Wadsworth Street between Symphony Circle and Days Park that we saw some new activity. Area E is Main and Utica. Main and Utica, we saw a significant increase in activity. That's one of our typical hotspots that was actually rather strange that we didn't see activity there earlier in the summer. And in Area D, we're seeing broadly activity pick up on the west side, particularly near Hampshire Street. So that's about it for me. If you would like to see more heat maps, please come to one of our webinars. The next one is on 10/20. You can follow that QR code, and I'm going to put a link to that in the chat. And thank you very much.
Thank you, Jason. Do we have
Yes.
any, I don't have the ability to see what's in the chat. Lee, I'm not sure if we have any questions lingering in there.
We do have one question from Dr. Burstein.
Sure.
Where you find more deaths compared to non-fatal overdoses, have you looked at the tox screens in the high overdose death rate areas compared to other overdose areas?
We looked at the tox screens in high OD death rate areas compared to other OD areas. Oh, like in terms of the substances that are detected. No, so we haven't looked at it in that way. We haven't looked at the non-fatal ODs to deaths ratio and using that to kind of and using kind of looking at the tox screens to predict that. That is would be worthwhile to do, however, and fortunately we have a brand new intern who is interested in doing that kind of work. So we will definitely look into that and put together a report for you.
Any other questions at all for Jason?
If anybody has any other questions, feel free to email our Bridge Erie email address. Questions, comments, concerns, any trends that you're seeing in your communities or your work that you're doing in, boots on the ground and stuff. We love as much data as we can obviously, get and compare. But we hope that this was beneficial for you. This is our first one, so thank you for being patient and bearing with us with these technical difficulties. We promise that moving forward, things will be a lot smoother. And hopefully we can have some open dialogue about some of the stuff that's going on. You can find any of our future presentations either on our website. There's a QR code there. There's also, like Jason had mentioned, he has some data webinars where we can share some of our data with you and our maps. If that's something that you're interested or you and your organization want to jump on board. We're happy to share that with you all as well. And then any other cool things that we're doing in the Office of Harm Reduction, please visit our website, which we are in the middle of revamping, which is kind of exciting. Yeah, Lee has been a huge part of that, so props to them. And we look forward to our next meeting next month. Thanks, everyone.
Thanks so much,
Yes, thanks.
everyone.